So for my case study, I have a 70-year-old Caucasian female currently receiving OT and PT after a fall that caused a fracture to her left humerus. She's currently non-weight bearing in her left arm and has a sling to support it. Her comorbidities include Alzheimer's disease, late onset, and other generalized epilepsy and epileptic syndromes. She's oriented ×1 and needs gentle reminders to adhere to her non-weight bearing status and to keep her left arm in her sling because she likes to take it out a lot. It makes her Alzheimer's makes it very difficult for her to participate in treatment and follow safety precautions as well as follow one-step instructions. After discharge, she will be discharged into assisted living where she previously lived before. She is married and her husband visits quite frequently, and they have 2 children that live out of state. Prior to her fall, Jane was able to dress and toilet herself independently. She is now dependent on staff for dressing, pericare, and pant management in the bathroom. She was previously minimum assistance for bathing and grooming, but is now a maximum assist. She ambulated without assisted devices, but is now dependent on a wheelchair due to her unsteadiness and on her feet and because she loses her balance a lot. She was dependent on staff and her husband for all of her IADLs prior to admission due to her diagnosis of Alzheimer's. She is still able to feed herself independently though. Some of her goals include showing independence with wheelchair mobility, improving strength in right upper extremity for functional activity tolerance, demonstrating increased safety with left upper extremity by adhering to non-weight bearing status, and improving functional balance by performing ADLs without loss of balance. For interventions, it's very important for her to be safely independent with ADL tasks. So functional balance is extremely important because if she can't stand and be safe with it, then she can't perform her ADLs. And because of her Alzheimer's, she forgets that she's unsteady and tries to stand up. To assess for improvement in functional dynamic balance, you can use a timed up and go test or a tug test. We did this in our no falls day, actually. And you just need a stopwatch and a standard armchair. And the patient wears regular footwear and they start seated in the armchair. When the therapist says go, they stand up, walk 10 feet to a pre-designated line, walk back and sit down. If it takes them 12 or more seconds to complete the test, they are fall risk. Doing this test allows for assessment of functional dynamic balance because as the balance is improving, their time will also improve. It can also be assessed during using a functional reach test, which during this the patient is instructed to stand next to but not touching a wall and position the arm that is closer to the wall at 90 degrees of shoulder flexion with a closed fist. The assessor records the starting position at the third metacarpal head on the yardstick, then instructs the patient to reach as far as they can without taking a step. The location of the third metacarpal is recorded, and the scores are determined by assessing the difference between the start and end position and the reach distance. This is usually measured in inches, and 3 trials are done, and the average of the last 2 is noted. So for the first intervention, I found a case study on where they used a Nintendo Wii and the balance board, which there's activities. You stand on a board and you perform exercises. They did this for 25 minutes, 3 times a week for 6 weeks. They all improved with their functional dynamic balance, which is important for activities such as grooming and pericare. The other one I found was also with a Wii, but they used the Wii Sports, and this was to improve functional static balance, which is crucial when reaching for objects and managing items during ADL tasks. Other possible interventions for this patient may include participation in dynamic standing balance activities to incorporate weight shifting, proprioception, and posture to improve standing balance for decreased fall risk. Instruction for wheelchair mobility tasks involving bilateral lower extremity working in unison with the right upper extremity to propel the wheelchair for independence of wheelchair mobility. Completion of right upper extremity exercise with a weighted dowel in all planes to improve right upper extremity strength, range of motion, and flexibility, to optimize function for toileting and pant management, as well as right upper extremity support for functional sit-stand functions. Another intervention could be therapeutic resistive exercise using arm cycler to improve functional activity tolerance while improving strength, range of motion, and flexibility for right upper extremity during ADL tasks. A combination of all these interventions will help Jane reach her goals and become as safely independent as possible.